Welcome back to another episode of the Health Roundup. It's been 4 months since I last did a video on this channel, and some of the key conversations that I had are actually a prelude to the conversation that I'm going to have with you today. I came back home from my studies in September 15th, and when I came back, one of the key things that I was intentional about is getting to re-engage with stakeholders, getting to understand what are the dynamics and what are the developments within the pharmaceutical and the healthcare industry in general in Kenya. And in those conversations, there's a pressing issue, and this is something that is personal to me, but also it is something that we need to get right for healthcare systems and healthcare to work in this country. And the essence of that healthcare system to work is to guarantee that for every single individual in this country of Kenya, whenever they go to the hospital, whenever they need healthcare services in whichever venue, form, or nature, they would be able to get that healthcare service. And the key pain point that gets to that point is financing of healthcare. Who pays for it? Why do they pay for it? And how do they pay for it? And I would say healthcare financing is a government obligation, but that government is us individual, because the government is for, with, and by the people. And therefore, then the question that you keep asking yourself is, how does the government intend to finance that healthcare for the common public and for the general public to ensure that we get the best healthcare services that we need, that we deserve, and that will keep us healthy as espoused in our constitutional right as a citizen within this country of Kenya? So in this conversation that I've been meeting people, having conversation and attending industry forums, one key thing keeps coming back as a pain point, and that is the ability of the social health insurance scheme to work, SHA, Social Health Authority, and its ability to process claims, to finance all the healthcare services and the needs that people have. But at the same time, from this conversation and these pain points that are coming, the general public are complaining they're not able to get their care funded and paid for by the insurance scheme. The hospitals that actually are supposed to offer the services are saying, because we are not getting reimbursed for these services, we are not going to offer them unless patients come with cash in hand, and that becomes a pain point. On the other level, or the third level, when you get with government officials, especially ministerial level officials, the key question is, how do we get more people to contribute? And how do we get people to pay to social health insurance scheme? Because the fund can only fund healthcare services and provision of care based on the amount of money that they've been able to raise from all the contributions that are coming from the members and people who are enlisted as beneficiaries of the authority. And that is a key principle and a key fundamental piece. Why did I say it is linking to the last video that I did earlier in May or thereabout? The last video that I did under the spark, it was about a conversation around how did the current president lose track of in terms of governing the country, and how does he have to bring it back? And one of the key things that I mentioned there was trust. And I look at trust as a key fundamental piece within the working of the social health insurance and what will make it either work or not work. And that fundamental foundation that we are talking about in trust is, when did we get to the point of having the social health authority, the social health insurance fund as it is, SHIF, whatever it is. And on that context, you realize that we were moving from the National Hospital National Health Insurance Fund, NHIF, to the Social Health Authority. Therefore, then there was a bill that was passed in Parliament to become the current law, the Social Health Authority Act. And in that context of those changes, there were key pain points that people still had. NHF was working but was not perfect, though it had its own abilities to deliver certain services. When this proposal came in, the initial operationalization, and one of the key questions I remember we submitted as Agriculture, Health and Social Innovation to the Parliament was, initially we have NHIF that was working. NHIF was repealed and we ended up having the Social Health Authority. But in having the Health Authority, NHIF used to process its own claim because it has its own claims department that was domiciled within the authority, and that was the key piece of what we were looking at. In this context with the new authority, we were saying we would contract a third-party service provider to process those claims. The question is, why do we have to pay an agency and then contract a third party to process the claims, yet its main mandate is to ensure, insurance is about processing claims and underwriting risk. The risk in this context is somebody is unwell in a hospital setting, and therefore when they fall ill and they've already paid their premiums, somebody should underwrite that risk and actually process the claim, which should be the core mandate of that agency. In this context, that was being transferred. That raises red flags for people, and actually people start questioning, do I want to trust this new entity? Subsequently, the contracting for the system development of the platform that was going to be hosting all our data and all the information, there were flaws. Onboarding process, they were talking about transferring data or not transferring data, people re-registering afresh and all that. Those were questions that were being asked. Unfortunately, that trust was being lost at that particular moment because nobody was authoritatively taking leadership to reassure people, to build confidence and actually explain what are the nuances and what the modalities and the challenges that were going to be envisioned in this context. And therefore, we missed a critical opportunity at that particular moment. And therefore, the general public did not feel like they would trust the government, they would trust the new mechanism that was coming in terms of social health insurance. And therefore, people go into it not because they want to, but because they are compelled to, and it is the government that is pushing them to the point where they have to accept it. So then we do it because we must, not because we want to. And how do you determine that actually that is the situation? When you look at the current data, the government is talking about, I would say, less than 5% of people who have registered into the new social insurance scheme. And the context of it is, these are people who are employed in formal jobs, which means automatically they are expected to make those payments. And even if they are not willing to make it, the employer will make it as a statutory obligation from their employment standpoint. How many other people have subscribed who are not in formal employment? Those who registered are not maintaining their payments. A majority of people, that is the situation where the government is at the moment. For those who are maintaining their payment, it is maintaining it because of maybe they have, I would say, they have a medical condition, most likely chronic conditions, and therefore that brings the issue of adverse selection. SHA will pay for me because I have a chronic condition, I have an obligation to do it, but nobody else is willing to put into the money and actually subscribe to that agency, and it is becoming our pain point and a challenge for the government. So, where the conversation that I see happening in all the contexts where I come to, patients and the general public are not willing to contribute to SHA. One, economic situation is very tight, so they don't have the money to pay. For those who have the money to pay, the question is, if the hospitals will not offer the service, if they are not being reimbursed, or the claims will not be approved, why would I pay for it? And yet when I'm sick, I will not get the care. Therefore, that is already a disincentive for an individual citizen to subscribe to the social health agency authority and actually to be a member of the insurance scheme. So that is already a failing opportunity. The third piece, what are the care pathways? The normal thing, and I think this is a conversation that I've had in my circles within the pharmaceutical industry, within the pharmacy profession, and general healthcare. Most Kenyans and most people don't go to the hospitals unless they are very sick. The first point of contact with their care system is the neighborhood chemist, the neighborhood pharmacy, because that is where they expect to get the care, especially in majority of the urban centers where we have more people. And even in the rural communities, people will still go to pharmacies because the hospitals are not as many and the distance to access them becomes a challenge. And when they do access them, getting the medicine is a pain point. Conventionally, we know, if I go to a hospital and I don't get my medicine, I'm not treated. So where do they go? Most people will go to their pharmacies, they go to their chemists and all that, which means that is their point of access to care. Unfortunately, as per the pharmacy benefits package that has already been rolled out and that were actually adopted during the passing of SHA, this has not been operationalized. Therefore, if I get registered and actually being insured under the social health insurance scheme, my first point of care is the pharmacy or the chemist, which is not a service outlet that is accredited and empaneled by SHA in this context. So what happens? I will not get the care. What is the incentive to pay if the point of care where I go to does not exist within the scope of service providers that would be able to serve my need? That becomes a pain. And in the situation where I go to a hospital and the medicine is not available, I'll be recommended to go purchase it outside, which means I need to go back to the pharmacy again. Where it is not available in the pharmacy, I'm already looking for alternative places. For the pharmacies that exist that have the medicine, I will pay out of pocket. So I am insured and I'm paying my own contribution to the insurance in case of sickness to cater for my care. But when I get to seek care, it is not being funded because the point of care that is available to me, that is accessible to me, is not enlisted as a service provision center. So that becomes a failed opportunity again to loop these people into the social insurance scheme. Providers, there's a key pain point again. We are not getting reimbursed, we are not going to be enlisted. And ultimately we get to a situation where providers and the government regulatory agency and the leaders are kind of getting into confrontations that are coming into the public light. Ultimately then, nobody trusts each other and these solutions cannot happen. On the other end, the government is saying, we need you to help us mobilize as many people as possible to contribute. Unless the communication speaks to the need of the person, it will not work, and therefore then people will not subscribe. People not subscribing means SHA will not have the money that they need to be able to process claims. If they don't process those claims, it is a chicken and egg situation. That vicious cycle will always continue. So we need to find a solution, and we need to find it as fast as possible, and we need to get our healthcare system right. What would be my proposal in the starting point? I would say some of the concerns that have been raised are valid and are genuine concerns that need to be addressed. But in addressing them, we also have to be honest enough to say there were things that were not done right. The architecture of SHA as it is, as per the law as it is, it has passed. That has to work. The architecture is about what facilities are there. What are the criteria and the recognition status of what makes it right and what makes it wrong? How do we process claims, and which claims do we reject, and what is the criteria? That has to be clarified, and in the clarification process agreeing, this is the service that you can offer in this hospital, this is what we would expect to be the criteria, and therefore we streamline the process. I agree, I acknowledge these things are already there. It is a matter of, can we communicate it in a way that we build trust and actually we institutionalize the processes to make it work for the common Kenyan. And then on the other end, we have to communicate with authority, with honesty, and with utmost confidence that we are serving the people rather than looking out for what is right. From healthcare professionals and health facilities, there has been cases of fraud, and that is an accurate statement of what the situation is. On the government side, there are some claims that have been processed that have not worked, have been raised that are genuine but have not been processed, and therefore when hospitals and health facilities are complaining, they are justified in that claim and in that concern. But the general public are the most affected, and healthcare service is about guaranteeing that when the common public and the general public who seek healthcare services go to the hospitals, they will be able to get that. That is a constitutional right. But if they cannot be guaranteed that care will be provided and will be paid for, then there's no way to convince them that they need to pay for that insurance scheme. And I look at it from the private insurance. When private insurers come to you and actually tell your service, they outline for you the benefits that you are entitled to. And those benefits are actually guaranteed that in case you fall ill, and if not, they will give you the waiting time before the cover comes into play. But in this context, you're told you will get the services, you will do everything. But at the point of care, patients are being failed. And that is a relationship between the insurer with the facilities who are the service providers at the point of care. Then the point of care has to build trust with the public, and the government has to meet that obligation. Unless we do that, we are failing each other. And the social contract we're under the Social Health Insurance Authority is, you are part of the social scheme because if you fall ill, we're having a social contract. We are guaranteeing you that when you're ill, you will get the service. But if that social contract is broken, as it has been broken over time and consistently, there's no way that you will expect these very people to trust you again. And if they can't trust you, they won't contribute. If they can't contribute, the insurance agency doesn't have the money to process the claims. Service delivery fails at the end of the day. It's high time that the government, the ministry officials, and even the general public, we hold each other accountable and ask ourselves, what do we want for the country? What do we want for our people? We need quality care. We need to get it right. If we don't, we are losing, and we're losing big time. Thank you, and let's keep the conversation going.